Chapter 39, Dysrhythmias. Possibly my favorite chapter within MedSurg is Dysrhythmias, because it really is that inner workings of the heart, that electrical conduction pathways that keep all the separate chambers and components moving in sync. And it is this electrical conduction system that we're witnessing when we read an ECG. It all starts reading left to right. That first bump is the P wave, and it represents atrial contraction. After that bump, you're going to see a pause, and that's what we call the PR interval. And that is that slight delay of the electrical conduction as it hits the AV node between the atria and the ventricles, giving things time to catch up before we have that big QRS complex, which represents the contraction of the ventricles, followed by another pause in the T wave, which is relaxation of those ventricles. Here's another diagram from figure 31.4 from your text, which breaks down each individual part of that ECG. But just reading left to right, you've got that first P wave atrial contraction, a pause for the PR interval, the QRS complex, that big ventricular contraction, a pause, and then the relaxation, represented by the T wave. Going deeper, you're looking at a 12 lead, and this is actually taking 12 different pictures of the heart. And once you know what each of those sections represents, we're actually looking at the electrical conduction from 12 different views of the heart. So if there is an infarction, we can actually see which part of the heart is having the problem. The first step to getting an accurate EKG is going to be accurate lead placement. And you're going to have diagrams on the machine. You're going to have it marked on your diodes. But it's key that you have those in the exact proper place so that we're getting an accurate picture. When reading an EKG, you can also set your timing of it. Each of those small blocks represents 0.2 seconds, so that 5 of those small blocks equals 1 second. If we get 30 of those, we have a 6-second strip, which is what we need to generally get an accurate reading. When calculating the heart rate, count the number of QRS complexes in 1 minute. Or an easier way is to count the QRS complexes in 6 seconds and multiply it by 10. When assessing that cardiac rhythm, first we want to look at regularity. Is each of those QRS intervals striking at a regular beat? If we start seeing it to be irregular, we know we've got some sort of dysrhythmia, possibly AFib or something else throwing off our timing. We also want to make sure that the patient is remaining still and not moving. Otherwise, we'll get what's called artifact, as the EKG will be picking up their movement as well as the heart's electrical system. For telemetry monitoring, this is the observation of the heart and rhythm at a distant site. Often when you're working on a telemetry floor, especially at the Cleveland Clinic, you would place your tele leads on the patient, and we have the big monitors up at the nurse's station where if we get an alarm, we can react quickly. But you also have someone at a remote site whose entire job is to monitor all of these telemetry monitors and call you immediately should a problem arise. Our first dysrhythmia is going to be normal sinus rhythm. In this case, the SA node fires 60 to 100 beats per minute, which follows a normal conduction system pattern, meaning it is regular. The P wave is normal and precedes a QRS, and the QRS has a normal shape and duration. Also, the PR interval is normal and not varying wildly. In the case of sinus bradycardia, this is a sinus rhythm, but is running slow, meaning that SA node is firing at less than 60 beats a minute. It could indicate a problem, such as a response to the parasympathetic nervous stimulation, certain drugs, other diseases, or underlying conditions. It could also be the patient's normal baseline, especially in the case of athletes. Their heart rate may run unnaturally low. Here would be a strip representing sinus bradycardia. Being a 6-second strip with only 4 beats, we can multiply that 4 times 10 and know that they have a heart rate of 40 right here. The treatment for sinus bradycardia is obviously going to be stop the drugs or treat the underlying cause. And in extreme cases, treat with atropine, a pacemaker, dopamine, or epinephrine. Next would be sinus tachycardia. It's the opposite of sinus bradycardia. In this case, we have a normal sinus rhythm, but it is running too fast, in this case over 100 beats a minute. Again, we're going to treat the underlying cause for this. They may do what's called a vagal maneuver, meaning having the patient bear down, tighten their abdomen. Others could be having them blow through an IV cannula, taking the plastic cannula off of an IV and having them blow through it. Anything to stimulate that vagus nerve and have the body hopefully pull down their heart rate to a safe level. We also may use drugs such as beta blockers, adenosine, calcium channel blockers, and in extreme cases, synchronized cardioversion. Next would be supraventricular tachycardia. This is like sinus tachycardia, but extremely fast, characterized as over 150 beats per minute. Characterized by a heart rate over 150 beats per minute, the heart rate greater than 180 leads to decreased cardiac output and stroke volume. The heart is going so fast it is not able to fill with blood properly with each contraction, resulting in hypotension, palpitations, dysrhythmia, and even angina. This treatment would also obviously include vagal stimulation, IV adenosine, beta blockers, calcium channel blockers, and synchronized cardioversion. Next would be a premature atrial contraction. As you can see from our arrows there, we have a normal rate and then a QRS complex, a beat that came too early, followed by a longer pause, as the heart tries to compensate, get itself back on the rhythm, before it again has a premature contraction. These premature atrial contractions manifest as palpitations, where the heart just skips a beat. The treatment is to monitor for more serious dysrhythmias, withhold any sources of stimulation, and beta blockers. Next would be atrial fibrillation. In this case, the atria just are not contracting, they're just sort of quivering on top, while the ventricles continue to contract as normal, which is why where it's manifest as those squiggly lines in between our QRS complexes. It is possibly the most common dysrhythmia, and the prevalence increases with age. Usually occurs in patients with underlying heart disease, though can occur with other disease states. As with atrial flutter, where the atria are just slamming open and shut, which is represented sort of like a sawtooth pattern, it causes a decrease in cardiac output and an increased risk of stroke, because these atria just sort of quiver and act abnormally, the blood pools at the top, allowing a clot to form, which is why the patients need to be on a blood thinner for quite a while. We've got to be very careful before cardioverting a patient with AFib, because your major danger is you're going to cause a contraction and then shoot that clot out the top. The treatment for AFib is drugs to control that ventricular response, prevent stroke or convert them to a sinus rhythm. Amiodarone, a ventricular dysrhythmic, is very commonly used for this. Other things like electrocardioversion, anticoagulation to again prevent that clotting, and radiofrequency ablation to destroy any abnormal cells that are sending out aberrant signals, or a maze procedure with cryoablation. Here's a diagram of that atrial flutter, and you can notice those P waves are like a sawtooth, shark tooth pattern. And in that case, the atria is just slamming open and shut with QRS complexes running relatively independently. It's going to be an irregular rhythm. Atrial flutter is typically associated with an underlying disease, and symptoms result from high ventricular rate and loss of atrial kick associated with an atrial flutter, decreased cardiac output, and can lead to heart failure, along with that increased risk of stroke, just like AFib. The treatment's again going to be a pharmacologic agent, electrical cardioversion, or radiofrequency ablation to destroy any cells sending out irregular signals. Next would be junctional dysrhythmias. These are dysrhythmias that start in the AV junction. In this case, the SA node at the top of the heart fails to fire, and the impulse is blocked at the AV node. In this case, the AV node becomes the pacer as a backup. It's not getting that normal pacemaker of the heart, the SA node at the top. We're falling back to that AV node, which resides between the atria and the ventricles, and that picks up the pace. We're going to have abnormal P waves because, again, we're not getting the proper signal through our atria, though we will have normal QRSs because those are still receiving signals as they should. Here's a diagram of that junctional rhythm, and you'll notice that it's flat. We're missing a P wave here because those atria are not getting an electrical signal to contract. It is originating after the atria, though we are getting the QRS. Also, you'll notice that it's at a much slower rate than it should be. That junctional rhythm serves as a safety mechanism. Do not suppress it. If the rhythms are rapid, it may result in a reduction in cardiac output. Treat the patient only if symptomatic, because again, this is the fallback. Without that, there is no other origination for the signal for the patient to fall back upon. Next, let's talk heart blocks. In this case, we have a first degree AV block, which is characterized by that prolonged PR interval. Next would be a second degree AV block, type 1, also known as a Mobitz 1 or a Winky block. In this case, it has a progressively lengthening PR interval until eventually the QRS complex is dropped completely. The Winky block may result from drugs or coronary artery disease and is typically associated with ischemia. Usually transient and well tolerated, though if symptomatic, treat with atropine or a pacemaker. If asymptomatic, just make sure to observe closely. Next is a second degree AV block, type 2 or a Mobitz 2. In this case, the constant PR interval and a variable blocked QRS complexes. A Mobitz 2 is associated with heart disease and drug toxicity, often progressive and results in decreased cardiac output and treated with a pacemaker. And finally, a third degree AV block or complete heart block. And you'll notice in this that the P waves and the QRS complex have no relationship and both are running independently. This is often associated with severe heart disease, some systemic diseases, and certain drugs. Usually results in decreased cardiac output, ischemia, heart failure, and even shock. Can lead to syncope, again treated with a pacemaker, and other drugs to increase the heart rate if needed while awaiting the pacing. And this is a premature ventricular contraction. Much like the premature atrial contraction, this is a premature beat, but in this case it is a wide ventricular beat with no atrial P wave connected to it. Here we have ventricular tachycardia, and you'll notice the big, wide, sawtooth pattern of the ventricles flapping uncontrollably. Here we have ventricular tachycardia form known as Torsades de points, and you'll notice how it gets larger and then narrower, larger and then narrower. And finally, VFib, ventricular fibrillation. This is our shockable rhythm, this and pulseless VTAC. In this case, much like the AFib where the atria are just quivering up top, in this case the ventricles at the bottom are quivering much the same way with no contraction. This is associated with acute MI, ischemia, cardiac procedures, and the patient is going to be unresponsive, pulseless, and apneic because there is no cardiac contraction with this rhythm. If not treated rapidly, death will result. Asystole. In this case, this is the complete absence of a heartbeat. No ventricular contraction. Again, the patient's going to be unresponsive, pulseless, and apneic, and must be assessed in more than one lead. This is pulseless electrical activity, which is interesting. In this case, the patient would have a normal would show electrical activity on an EKG, looking like they have a heart rate. But when you check the patient, they are pulseless and apneic, which is a great lesson. Always be assessing and treating your patient. Don't treat the machine. Pulseless electrical activity could result from hypovolemia, hypoxia, any number of hypoglycemia, hypothermia, tension pneumothorax, traumas, or toxins. Sudden cardiac death. Most sudden cardiac death results from ventricular dysrhythmias. Upper dysrhythmia. This is a life-threatening dysrhythmia caused by anti-dysrhythmia drugs. Severe left ventricular dysfunction can increase the risk, along with digoxin, and is most susceptible in the first few days of drug therapy. Defibrillation. In the case we've got pulseless VTAC or VFib, we're going to need to shock them. This is that treatment of choice. It's most effective when completed within 2 minutes of that dysrhythmia's onset. And it's the passage of electrical shock through the heart to depolarize those myocardial cells, attempt to reset that erratic rhythm. Here we've just got an example of a monophasic defibrillator that's delivering a shock in one direction. Not to be confused with a biphasic defibrillator, which delivers its shock in two directions. Here we just have an example of those two different types of defibrillators with a monophasic on the left and a biphasic on the right. Output is measured in joules or watts per second, with the recommended energy output being for a biphasic machine 120 to 200 joules, or for a monophasic 360 joules. Some tips, just remember back to your BLS. Continue CPR until the defibrillator is charged. Turn on and select proper energy level. Make sure sync button is turned off. Apply gel pads. Charge that defibrillator. Position the paddles firmly on the chest wall. Ensure everyone is clear. Anyone touching that bed will be shocked. And deliver that charge. Synchronized cardioversion, which we've already touched on in the cases of dysrhythmias like SVT or supraventricular tachycardia, is that therapy of choice, ventricular or supraventricular dysrhythmias. And this is synchronized circuit that delivers a shock to the R wave of the QRS complex, and it takes to capture the rate that the heart is beating. Here I've just included a diagram from a different text of these cardioversion steps. We may also see an implantable cardioverter defibrillator, and this is appropriate for patients who have survived sudden cardiac death, have spontaneous sustained ventricular tachycardia, or have syncope with inducible ventricular tachycardia or fibrillation, and they are at high risk for future life-threatening dysrhythmias. On the left, we have the implantable cardioverter defibrillator, that ICD pulse generator. And on the right, on figure B, we have an ICD that's placed in the subcutaneous pocket over the pectoral muscle. A single lead system is placed transvenously from the pulse generator to the endocardium. The single lead detects dysrhythmias and delivers an electric shock to the heart muscle. Patient and caregiver teaching. Make sure they're attending follow-up appointments, closely assessing and keep tending to that incisional care. Arm restrictions, restricting sexual activity, restrictions on driving, avoiding direct blows, and avoiding large magnets. Also keep in mind that air travel is not restricted. You want to avoid anti-theft devices, and what to do if that ICD fires. The medic alert ID, notifying paramedics and others that the patient does have an implanted ICD. Here in figure A, we have a dual chamber rate responsive pacemaker, and it's designed to treat patients with chronic heart problems, in which the heart beats too slowly to support the body's circulation needs. And in figure B, we just have a diagram showing the pacing leads in both the atrium and the ventricle. In the case of pacemakers, these are cardiac resynchronization therapy, and they resynchronize the heart cycle by pacing both ventricles, or biventricular pacing. Here in figure 35-27 from the text, we have a temporary transvenous pacemaker. And here we show a 12 lead showing that temporary pacemaker, and you'll notice those spikes within our EKG strip, and each of those spikes is the firing of the pacemaker. And finally, ablation therapy. In this case, they're going to go in there and they're going to cauterize and take out any cells that are sending out errant signals causing a dysrhythmia. ACLS and dysrhythmias are a fascinating area. Those of you that go on after graduation, I'd encourage you to find a job on a telemetry floor. Find a job. Many of them are going to make you get your ACLS certification. You know, it's a several-day course, but it also takes a lot of practice to really get good at reading those strips. But it's also a serious asset to you as a nurse. I'd encourage you all to go out for get into the ACLS deeper once graduating for sure. Anyway, that's all we have for this chapter. I'll see you in the next slides.